we will start MDT discussion for the diagnostic and treatment of oligometastatic prostate cancer. Moderators will be Dr. Stepanavich, radiotherapist, me, Kardelis, urologist, and we will have help. Another one, radiotherapist, Dr. Slidevska, and oncologic therapist, medical oncologist, Dr. Asadauskine. So we will start.
So, hello once again to everyone. Let's jump into the first case without any hesitation, I suppose. 74 years old male patient with dysuria and nocturia was diagnosed with an increased PSA of 9.8 nanograms per milliliter at the time in 2011. A systematic biopsy was performed for the patient, which showed that patient has prostate carcinoma of Gleason score 3+3, with 3 cores being affected and affecting up to 60% of the core. External body radiation therapy was prescribed. The 74 grays was delivered to the prostate with 2 grays per fraction, and as we can see from the slide, the PSA level decreased and remained stable for a few years. And in late 2016, the patient PSI level started to increase, and by early 2018, it reached almost 3 nanograms per milliliter. And pelvic MRI was performed. Maybe we can see those images, please.
Please connect microphone.
Okay, hello. Can we share the screen? So where is the images? And on MRI, we see a focus in the right transitional zone here. With contrast enhancement, but there is no any diffusion restriction in this side. So by radiologist, it was decided that it could be an adenoma. Do you see images or not?
Yes, we do. Okay. We do see MRI.
So in the right lobe transitional zone here, there is a focus of contrast enhancement, but any diffusion restriction in the site, so it could be adenoma. And at this time, for local recurrence in the prostate, there is no sufficient data. So, you seen us?
Yeah, so maybe we could jump back into my slides. Yeah, so as Dr. Narushevichuta told, there was insufficient data to prove local recurrence, but also I suppose lesion in the left pubic bone was also visible at the time. And bone scintigraphy was performed to rule out metastatic disease. Maybe Dr. Tiškevičius wants to add something on that matter.
Yes, we can see the report, but at this time point, there were any lesions suspected for bone metastasis.
Yeah. So and after the bone scintigraphy, further surveillance was recommended for the patient, and pelvic MRI was performed for a patient years later. Dr. Narashevichuta, would you be so kind to
Okay,
shed
so
some
can we
light?
share the slides from my computer? So on MRI, we see a new focus of contrast enhancement in the side in the left lobe. The focus what was seen earlier is the same, of the same size, contrast enhancing without diffusion restriction. And in the left, there is contrast enhancement. Where we don't see any diffusion restriction. So it was interpreted as possible prostatitis, but for recurrence, it's not sufficient data at this time. And
Thank
the
you.
focus in the pubic bone, it's not suspicious for metastasis, just for follow-up.
Thank you. Would you be so kind to put my slides back in? Thank you. And however, the PSA level continued to grow, and again, whole body MRI was performed for a patient. Also, half years later, again, Dr. Narashevichuta, would you be so kind to shed some light on this matter?
Of course. Can we share my slides? So on whole body MRI, we see a focus in the left. Just a minute. Some changes are seen on GVI here, this place, but there's no any. But diffusion restriction is not so big, and the focus is very small. It's mostly the same place that was seen contrast enhancement in earlier images, but from whole body MRI is difficult to say it is recurrence or not. So it's just suspicion from these images. Okay.
And pelvic MRI was performed after the whole body MRI. And would you be so kind to comment on this pelvic MRI?
Yes, of course. So can you show my images? So where is the focus in the left lobe, peripheral zone, with contrast enhancing what was in earlier images, but now we see the diffusion restriction in this place. So it's suspicious for recurrence. And the focus in the right lobe is the same as it was earlier.
Thank you. Additionally, bone scintigraphy was performed to rule out a metastatic disease. Dr. Tishkevičius, do you want to comment something on this matter?
No.
So
that's the
no evidence of pathological osteoblastic activity was visible. And multidisciplinary tumor board meeting was held in July. And well, the question for our experts probably what the following actions should be taken. Please discuss.
What do you prefer? Maybe people start from medical oncologist. What you can help for this kind of patient?
Here is a local progression of disease, and I don't know, maybe a urologist can advise, give advice. Maybe verification, morphological evaluation will be reasonable in this case.
Yes, maybe you agree that we could try to try once again about local treatment, not systemic.
Yes, not systemic.
So
yes, I agree with you.
Field will be in different place to radiotherapist and urologist. Yes, so according to possibility radical prostatectomy as urologist, maybe we have online on urologist Januszkiewicz, maybe he has some comment.
I think we need histological verification.
Do you recommend for this patient RP?
Not now, I think.
So it's you recommend biopsy not for intense for future radical prostatectomy.
I want to see what histology.
So maybe due to possibility of radical surgery is quite complicated after primary radiotherapy. Because after that we expect or possibly will expect a quite big percentage on severe incontinence and maybe difficulties with quality of life. So I will ask about possibility to treat locally for our colleagues, the doctors, radiotherapists.
Actually, this possibility it's quite attractive for local treatment, for focal treatment. But first of all, I would like to ask, and I would like to remind that we should provide biopsy. Yeah, I think. And for verification.
Recommend of a radiotherapist secondary
previously,
line treatment.
In future. First of all, biopsy, and after that we'll think about. I suggest about local treatment, and I have actually a couple of questions to Justinas. First of all, does a patient have some urinary problems or after definitive radiation therapy, because it was long time, I guess 6 years or 7 years,
He was treated in 2011.
Mm-hmm.
9 years.
And no, he has no expressed urination problems at the time of multidisciplinary tumor board meeting. At the time of that meeting.
And at the beginning, the stage of disease was T3, and what was the stage? I didn't catch the stage of disease.
It was T3A.
Yeah, it was good result for stage 3 disease. Don't you think so?
I suppose so.
So, board, we will determine that we will go to line of secondary radiotherapy. So we will start from biopsy. So
would the administrator be so kind to put me back on my slides? Thank you. And it was decided to perform biojet biopsy, and there were, of course, from 1 to 5 sampled from target 1 in the right lobe, and of course 6 to 12 sampled from the left lobe. It is worth mentioning that the ultrasound did not visualize both targets, and course 2 and 3 from the right lobe, and course 7 from the left lobe contained acinar carcinoma of the prostate with up to 35% of the core affected. Maybe we have some comments from pathology department on this case.
Yeah, sure. Do you see my screen?
We see.
Yeah, okay. We have positive findings in 3 biopsies, 2 from right and 1 from left focuses, and this is one of biopsies from right, and up to nearly 5 millimeters in length, we have Gleason 4 plus 3 tumor in this focus with histologically seen of fusion of the glands and some scattered single isolated glands. So it should be noted that when patient have some therapy, for example, radiotherapy or hormonal therapy, on pathological ground in pathological literature, it was limitation to classify tumor according to Gleason score, but still in this situation it was put it in the note section, but tumor is of Gleason grade group 3 or Gleason 4 plus 3 category, up to 5 millimeters in highest length.
I would like to ask pathologist, acinar adenocarcinoma comparing with adenocarcinoma, pure adenocarcinoma, is better prognosis for patient, or it's no difference?
Pure adenocarcinoma, you mean maybe ductal adenocarcinoma, because let's say acinar adenocarcinoma is conventional acinar adenocarcinoma, mostly found in the prostate. So it's if we comparing acinar adenocarcinoma with other carcinomas, for example ductal, yes, acinar adenocarcinoma have better prognosis.
So can you jump back to
Can I ask pathologist, sorry?
Yes.
You mentioned now, perhaps we talk maybe with you or someone else, or maybe between us, maybe radiation oncologist. Again, the same question. After radiation therapy, you always saying that you don't like to score Gleason score. So is it still the same as what you said right now?
Yeah, it's the same. It's some in the WHO Blue Book. It's stated that when patient have undergone some therapy like radio or chemo or androgen deprivation therapy, it could impact on Gleason on tumor appearance. So it's not recommended to make grading of the tumor, but we still make the at our department we still make the status of a Gleason score in the note section.
Okay, thank you.
So the multidisciplinary tumor board meeting was held again in August, and how do you think what our following action should be for this patient? Again, please discuss. We have a verification now, and what kind of treatment you would suggest for this patient?
question from first line is about the local surgery. I will start talk. As I mentioned previously, salvage prostatectomy after previous first line local radical radiotherapy is quite have a big challenge due to possible complicated quality of life for patient due to high risk of severe incontinence. So after radiotherapy first line, we will not recommend to do salvage prostatectomy. If we can choose, we will ask help for the radiotherapist. So the next question to radiotherapist.
Yeah, actually, I think we would go for brachytherapy, of course, because to repeat radiation, external beam radiation therapy, it's quite risky as well, because as you said previously, it was used 3D technology, and I suggest actually at that time it was no image-guided radiation therapy, as far as I know, in our department, and he was cured in our department, I guess. So I would go for brachytherapy, but actually, and it would be the best choice. Actually, I'm not sure about cryoablation. Maybe it's a quite nice possibility as well. I'm not sure about that. Yeah, maybe you can just, maybe we can have a look what decided MDT.
Yeah, so please, thank you. It was decided to perform salvage hydrogen brachytherapy. Two procedures were executed. 11 grays to the prostate and the base of seminal vesicles were delivered during each procedure. And as we can see from PSA dynamics, PSA dropped, and currently the patient is under surveillance with a stable PSA level. That's it with this case. Maybe we want to discuss something else, or we can jump to the second one.
I just have one question for medical oncologists. If you please return back one slide, once more. If you back one more slide, and more. Okay. What your opinion about the androgen deprivation therapy in local prostate cancer? Is it an option?
In this case, I prefer local treatment methods and later observation. But we can discuss also maybe intermittent androgen deprivation therapy too. But my preference local methods and after observation.
Because systemic androgen deprivation therapy in local prostate cancer did not prolong it overall survival. Yes.
Yes, and side effects, of course.
Okay, thank you. Next.
So let's jump to the second case without hesitation, and increased PSA of 17.3 nanograms per milliliter was found at 67 years old male patient with nocturia in 2011. A systematic biopsy was performed, which showed that patient has prostate carcinoma of Gleason score 3+3 in one core. According to the MRI images, there was visible T3B stage prostate cancer, and the patient was prescribed with the external body radiation therapy with 76 grays delivered to the prostate and seminal vesicles. Also, the patient has been prescribed hormone treatment. After the treatment, there was a decrease of PSI. However, PSI started to climb, and a pelvic MRI was performed in 2016. Do we have these images, Dr.
No, these images we don't have.
Oh, okay. So there was no signs of enlarged lymph nodes or signs of local progression. And PCA remained stable for a time, and pelvic MRI was performed years later. I suppose we do have these images.
Yes, can you show my screen? So on the MRI images in the right low peripheral zone, there is a focus of contrast enhancement and diffusion restriction. So it's very suspicious for local recurrence. This is a small focus of 7-8 millimeters in size. So, Justinas?
Can we jump back? Yeah, thank you. Wrong slides. Yeah, this one. Thank you. So pelvic MRI was performed, and PCI increased even more, and bone scan was also performed, and there was no evidence of pathologic osteoblastic activity. However, PSI increased further on, and thrust biopsy was performed to the patient, showing a recurrence of the disease. 7 out of 10 cores were affected in both lobes, and Gleason score increased from the previous biopsy also. Maybe we can have a comment from a pathology department.
Yes. Do you see my picture?
Yes, we see.
Okay. So in biopsy from both lobes, we have also positive findings of Gleason from Gleason 3+3 to Gleason 3+4 adenocarcinoma, and even Gleason 4+3 with predominant Gleason 4 pattern. And this is one of 3 of these biopsies. So in one biopsy, we can still identify the tumor of about 3 or 4 millimeters in length, with Gleason 3+4 and Gleason 4+3 category, with glands fusion with, and also with scattered glands. So positive findings.
Thank you. And there's a time for a multidisciplinary team decision. So what our following actions should be? Would you be so kind to discuss?
So maybe now we'll start from Ask Radiotherapists.
Yeah. First of all, I would like to ask a question. This patient, he received radiation therapy plus hormonal therapy. What was after that? Is he still receiving hormonal therapy, or just he quitted it at some point of time?
Hormonal therapy was discontinued after 2 years of usage.
After a few years of usage, yeah? After he finished. Okay. And what else? Lymph nodes were irradiated to this patient, and at the previous patient was not irradiated. Actually, it's always a tricky question for radiation therapists. Always. Does pelvic node irradiation improve overall survival? And at some point, I guess about 6 or 7 years ago, it was mandatory to irradiate lymph nodes, suggesting Roche formula, yeah. And nowadays, there are plenty of studies that suggest that lymph node irradiation didn't improve overall survival for those patients. And it's always a tricky question. And because I would like to explain, because when we irradiate bigger volumes, the toxicity is, of course, always bigger. And actually, radiation therapists, we always want to irradiate as smaller lesions as it is possible. and I wonder why for the first patient it was not radiation lymph nodes, because the timing is more or less the same, 2010 or 2011, and for the second patient it was irradiated. Or maybe you know, maybe you have read some information why it was this decision made at that time.
Well, unfortunately, I do not have specific knowledge why this decision was made and why not. And well, unfortunately, I cannot provide the answer this time.
Can I interrupt?
Yep.
I just want to pay attention to, yes, you said very right that two different patients, but they are different in like kind of strange, because first one was Gleason 7, this one was Gleason 6, 3 plus 3, like 9 years relapse. No recurrence. It was okay. This one was irradiated with lymph nodes. Previous was not. And again, the success story is more successful for first patient. So that's absolutely like not logical things. It's my just comment.
Yeah, it's because you are a radiation therapist as well, so that's why I say it's a tricky question for all of us. And also, I would like to ask urologist, and do you suggest maybe in some cases you suggest surgery after radiation therapy, or it's definitive no, and that's all?
Urologists can perform such kind of operation after radiotherapy of first line, but every time must have in mind that the unreversible complication will occur, especially as I mentioned before, such as incontinence. So if you have operated as first line patient radical prostatectomy and you have incontinence, this is sphincters or slings performed, results are better because side effects on neighboring tissue of radiotherapy occurs also. It's and reviving of this tissue are very complicated. So it's secondary supportive treatment for this patient will be very complicated also. So it's quite not welcome among urologists perform such kind of operations. Only as not as a cancer treatment or only perform as complications, local complication treatment as necrosis of mainly necrosis of vesical bladder as cystoprostectomies. So that's another.
Yeah, and maybe Dr. Arnas, you are urologist, yeah, as far as I know. Maybe you. Huh? Yeah, maybe you know, is it some safe timing after radiation therapy? For example, after 6 years or after 7 years, we can operate prostate, or there is no, let me say, safe timing after radiation therapy. As said Dr. Kardelis, it's always difficult to operate after radiation. Maybe.
I think it's very always difficult to operate on patients who had radio-recurrent prostate cancer. Now, if I would like to also say my thoughts on this case. I feel that like even the initial diagnosis is probably not correct. You know, only one biopsy positive for 3+3 disease with a large lesion of in MRI suspicion T3B disease, and patient recurs just after discontinuing the ADT. So I think there's probably was more cancer hidden in that prostate to begin with. Now, This patient has currently a local recurrence with MR visible lesion on the right, while the significant disease is on the left side of the prostate. So I think with this tricky situation where we're not really sure what is happening, I think a PET PSMA scan should be performed to really exclude that the recurrence is only in the prostate. Now, to operate this patient or not, I think the decision is based on how fit is the patient and can he really benefit from this type of surgery, and will he accept the high toxicity of surgery that he's most likely going to be incontinent and he will forget about his erections. So it also has to be really a discussion with the patient on what to do next.
And maybe a radiologist can just add something about PSMA's scan. Maybe Eva or Sigitas can add something about it.
Yes, there is an option for image such patient, but we know the availability in Lithuania of this scan. So
maybe in the near future, you have feeling we'll have it or no?
Yes, I hope so. With the opening of cyclotron in Kaunas, so then it's. I suppose in Lithuania we start with this PSMA PET scans, but at the moment there is any possibility in Lithuania.
Thank you. So maybe we can go further with that case.
Yeah, so multidisciplinary team decided to perform salvage high-dose radiobrachytherapy, and there was 2 fractions of 11 grays delivered to the prostate and base of seminal vesicles. The patient had a decrease of PSA level from 10 to 5 nanograms per milliliter. However, PSA started to climb soon, and well, here we go. PSMA scintigraphy was performed, and maybe Dr. Tiškevičius may shed some light on this.
Yes, at first I want to stress is not PSMA PET, but this is PSMA SPECT imaging. And in National Cancer Institute, we have a trial with PSMA SPECT imaging, and this patient was imaged. So here we can see a local lesion in the prostate gland, and no other PSMA positive lesions outside prostate wasn't found. So only solitary lesion in the prostate.
Thank you. And patient was further observed, and a whole body MRI was performed later. Maybe you have images of this investigation.
Yes, can you share my screen? So on MRI images whole body, there is some diffusion restriction in the right lobe. So it could be suspicious for local recurrence, but whole body MRI is not so specific for local recurrence. It's more for distant metastasis. So in this case, it would be recommended to do pelvic MRI, multiparametric, to say this suspicion, it is really local recurrence in this site or not. So, Justinas?
Thank you. As you have seen previously, PSA continues to grow, and bone scan was also performed for a patient in September of 2019, and there was no evidence of pathologic osteoblastic activity. And with PSA continuous growth, red biopsy was performed for this patient. maybe we can have some comments from pathology department.
Yeah, one moment. Unfortunately, I have only verbal comment. No pictures. But from 12 biopsy course, we have positive findings in 3. Unfortunately, we don't have information in which part of a prostate it was, because it was no classification of by urologist from which lobe was taken. But still, we have prostate cancer. In 2 biopsies, it was quite minimal, up to 1 millimeter in length, and in biopsy 4. It was a little bit larger tumor, up to 2 millimeters in length, and also it's the same case. What was the previous tumor was. Patient have some therapy, and tumor have therapy effects on. So we don't apply at this cancer the Gleason staging.
Thank you. Can we jump back? Yeah, thank you. So again, it's time for a multidisciplinary team decision. And what treatment options we can choose for this patient? Please discuss.
As local radical prostomy is quite complicated, so due to such a situation, maybe will I ask about medical oncologist. Maybe at this time see some place for her.
As I understand, the distant metastases are not detected yet, and the progression is local.
Yes,
And maybe I say maybe local. It is possible still local therapies in this case, or not.
Yes, you're right. So
Maybe we can ask Alexandras. He's medical oncologist as well.
Hello, everyone. I would agree with Dr. Zdauskina. If there is a possibility of local treatment of some kind, I would withhold ADT for now. Of course, if there is no possibility, then we are out of options. So maybe surgeons or radiotherapists.
I do think that Dr. Arnas wants to put some input.
Yes, I just didn't understand if where the biopsy is only positive on the right side of the prostate where we have the suspicious lesions. Was it only the side that was positive, or was it both?
Would you be so kind to turn my screen? Unfortunately, we do not have that information, and it's a bit tricky here, and well, we cannot answer you this question.
Okay, so if given that the biopsies are only positive in the right-sided MRI lesion, you could still perform the focal HIFU in this patient if you clearly see the lesion and if the biopsies are concordant with the lesion. Otherwise, I would not treat this patient probably, because a radical prostatectomy after brachytherapy and radiotherapy is going to be a very high toxicity treatment. Even salvage focal therapy will definitely be more risky than primary treatment. So yeah, I think if in case the biopsies are concordant with MRI, focal salvage is still possible with HIFU in this patient.
So thank you for your opinion. Maybe someone else wants to input something. into the discussion.
Actually, I wanted to ask a question. What is time gap between first and the second biopsy?
And between first and the second biopsy.
Yep.
Can
Yep.
you jump into the slides?
When we had already recurrence and just it was made 2 biopsies. Yep.
Yeah, it was the first biopsy was made between January and March in 2018, and the second biopsy was performed at the January in 2020. So it's 2 years.
2 years.
Biopsies, give or take.
Mm-hmm. And the brachytherapy was applied at the site, the same site that was biopsied the second time. Or
no, brachytherapy was applied to the whole prostate.
Okay.
So I do think that we can continue. Hormone therapy was prescribed for the patient, and with the hormone therapy, we see. Would you be so kind to put back the slides, please? Thank you. And with the hormone therapy, as we can see, the PSA level decreased for a patient, and currently he is under surveillance with a decreased PSA, and that's it with this case. Maybe you want to discuss something else?
Quality of life of this patient is quite nice, I guess. Yep. After all interventions and all radiations.
I suppose so, but unfortunately we do not have the data to confirm or deny.
He's a very nice person, if you will not ask. Yes.
No, I'm just curious because 10 years of diagnostic procedures of various types of treatments, and just I just was wondering how patient is doing with us.
As I said, unfortunately, we do not have any confirmed data that can confirm his well-being at the moment. But I think that urologist that perform the surveillance may ask him how he performs in the case of his well-being and quality of life.
I would like to ask Dr. Sadauskine about ADT for this patient. Would you recommend intermediate hormonotherapy or long-lasting treatment?
I prefer intermittent hormonal treatment.
Goes to receive less side effects. Thank you. Do you have questions or recommendations?
So I do think that we can jump to the last case. Okay. So 57-year-old patient was diagnosed with increased PSA, which was up to 87 nanograms per milliliter at the time of the diagnosis. A pelvic MRI was performed. According to MRI images, there was visible T3B stage prostate cancer. Biopsy was also performed. It was found out that the patient had prostate adenocarcinoma with Gleason score of 3+4. All 10 cores were affected with the 100% involvement in some of the cores. Additionally, a bone scan was performed to the patient, and no bone metastasis was visible at the time. It was decided to give hormone therapy to the patient and radiation therapy to the prostate, seminal vesicles, and regional lymph nodes. After the radiation therapy and ongoing hormonal treatment, patient's PSI dropped to 0, but unfortunately the patient did not come back for his surveillance, and from 2015 to 2020 was not followed. Finally, he showed up for a checkup in 2020 with microhematuria and a PSI level of 20 nanograms per milliliter. MRI was performed for a patient, and maybe do we have those images, Dr. Eva?
Yes, can you share my screen? So on MRI images, there is no contrast enhancement in the peripheral zone, whereas contrast enhancement in the transitional zone, but it looks like more than like adenoma, not local recurrence. There is no such diffusion restriction, and it is seen some changes in the left iliac zone, but it looks like more like fat necrosis with some contrast enhancing places in the peripheral side of this fat necrosis. So it looks like more like post-operative or some post-therapeutic changes, but not local recurrence. It's not sufficient data for local recurrence. So, Justinas?
Thank you. At that time, bone scintigraphy was performed, and maybe Dr. Tiškevičius wants to add something.
There were any lesions suspected for bone metastasis. Also, we perform low-dose CT because we do this SPECT CT examination, and we report also the findings seen on low-dose CT, and there were enlarged right common iliac lymph node and also para-aortic lymph nodes on low-dose CT, but no bony metastasis.
Thank you. Do not go far away because PSMA SPECT CT was also performed for that patient, and maybe you want to comment these images also.
Yes, as we see, it's red arrow. There are enlarged para-aortic lymph nodes and right common iliac lymph node with PSMA expression. So it's very suspected for metastasis. Also, there are lymph nodes in left groin area, also with PSMA expression. So very suspicious for metastasis.
Thank you very much. The slide just summarized what Dr. Tiškevičius just said, and PCA dynamics was as shown in the slide. And question for our experts: what treatment option would you recommend for this patient? Is it the hormonal therapy and left groin lymphadenectomy, or maybe hormonal therapy, left groin lymphadenectomy, and radiation therapy at para-aortic lymph nodes, or maybe it's hormonal therapy and radiation therapy to all involved lymph nodes? Maybe you have some other options. Please discuss.
I know the decision of MDT for this patient, but I would like to ask maybe doctors from other institutions and maybe Dr. Rakauskas, your opinion in this case?
Yes. So I think in this patient, he has still a PSA of 20. So the PSA PET scan really tells us all the story. That's a good question. I think what could be attempted if really there's only 3 metastases, what makes this patient oligometastatic, would be stereotactic radiation therapy. Now, again, he has PSA of 20, so I really doubt that these are only the 3 metastases. I think what is most likely this patient will end up on long-term ADT treatment.
Then 3 metastases. 1 para-aortic, 1 iliac, and in left groin. What about surgery in left groin?
In our institution, we wouldn't perform surgery in this kind of case. Either stereotactic radiotherapy or ADT treatment.
Yes.
Well, would you be so kind to share the slides? Thank you. Well, in this case, there was it was decided to perform stereotactic radiation therapy to the left para-aortic lymph nodes and perform the left groin lymphnodectomy. Also, the patient was prescribed hormonal treatment. So as we can see, there were all three options involved into this case. And histology examination after the lymphnodectomy showed that there was adenocarcinoma metastasis in the left groin lymph nodes. There was an extranodal extension with lymphovascular invasion. Maybe there's something else that the pathology department wants to add.
Yes, one moment. Yeah, all three lymph nodes was infiltrated by tumor, and it's up to metastasis up to 40 or 15 millimeters, and tumor was of poorer differentiation than in the first biopsy. It looks like a tumor. Okay, we don't categorize. We shouldn't categorize tumor in metastatic situation also by literature, but still, as you remember from my lecture, some authors recommend to classify this tumor according to Gleason. So tumor is about Gleason 4+4 or maybe 4+3 with predominant Gleason 4 pattern. And of course, it was extranodal extension, and of course, it was lymphovascular invasion of a tumor.
So thank you for your comment. And BSA decreased after the treatment and with the ongoing hormonal treatment, but started to climb again, and whole body MRI was performed. Do we have images of the whole body MRI? And also, maybe I will explain right now that patient it was decided to continue with the hormonal therapy, and the follow-up MRI was also performed after 6 months. And maybe Dr. Eva can compare those two images with the which were taken under the ongoing hormonal therapy.
Yes, can you show my screen? So where is the images here of 2021 years on December, and we don't see any lymph nodes in the para-aortic side or common parailiac zone, but in earlier images on 2020 September, where is seen a clear of increased size lymph nodes in the para-aortic site, and some lymph nodes of a little bit increased size in the common iliac site, here and here. So in the new images of follow-up, we don't see these lymph nodes. Christiane?
So, thank you. And currently, the patient is under the treatment of under the hormone treatment and under further surveillance. So that's it with this case.
My question is it enough for this patient, only ADT? Because summarizing, we have metastatic hormone-sensitive prostate cancer, low volume according to charted criteria, and international recommendations, NCCN, ESMO, others say that ADT for most patients in this situation is not enough. That my questions for discussion.
I will mention this patient has his own point of view for the treatment, and he's not on ADT now. And after surgery and
Preference of patient, only
yes.
ADT.
And I think that he will make a gap for 5 next years.
Yes.
Like after radiotherapy.
Yes, I understand. And the other problem is that in the hormone sensitive metastatic prostate cancer setting, we have no reimbursement of novel anti-androgens in Lithuania, and chemo is not acceptable for some patients.
What will you offer for this patient after that? For example, ADT plus or
novel anti-androgens. I will offer if that possibility, if reimbursement will exist in Lithuania. Because chemo, I don't know.
Is it possible to treat only with novel drugs without hormonal therapy?
No. ADT is necessary.
Despite that, local treatment was quite effective, yeah, as I see.
Yes.
But
very good.
But we all keep in mind that you will need ADT as well, yeah, because we see that disease is in progress actually.
Yes, because it's M1 disease.
Yeah.
M1 disease.
But he's in a good performance status now, and never mind.
I also want to interrupt you, and I agree with radiologists just now. And nowadays we have some data which shows that in selected patients, such like him, it could be place as for activity and for local treatment also. Some patients very selected could have benefit for local treatment, so it's not first detected. Thank you.
So maybe we can jump to the last hour case.
Last case, maybe, please.
So hello again. So the last case for today, for our discussion, is about a patient of 56 years of age with a initial PSA level of 52 nanograms per milliliter. So the on first MRI scan, we have seen a PIRATS 5 lesion in the prostate. I cannot tell you where exactly because the MRI was not done in our institution. And the stage was RT3B. And on bone scan, metastasis on the 5th left rib was found. So it would make it RT3B M1, sorry. So in 2018, the rib resection was performed. What have we found on histology was adenocarcinoma. And after this, prostate biopsy was done. Histology came back from prostatic adenocarcinoma Gleason 7. Again, I cannot tell exactly which Gleason 7 because it was not performed in our institution. So the treatment for the patient was started. Hormone therapy was prescribed, and also he received a radiotherapy to the side of a rib resection. Also, later a radiotherapy to the prostate with the HDR and external beam radiotherapy. His PSA level dropped to 0.5. However, later it started rising again to 5.3 nanograms per milliliter. And we can see that in 2021 on SPECT-CT we have found a metastasis in the right tibia. So 1 month later, the PSA was at almost at 10 nanograms per milliliter. So it is continuing to rise. Patient is on ADT, on androgen deprivation therapy. And in this year, January, troponin biopsy of the right tibia was taken. And what came back was a prostatic adenocarcinoma with necrosis and fibrosis. So for the discussion, I would go straight to the treatment. What treatment would you recommend in this case?
If I could interrupt.
Yeah.
I have images of MRI, so I could, if you could share my screen, I would show. So you see my images or not?
Yes.
Yes. Okay. So on 2018, we on MRI there is a large focus in the right lobe, in the peripheral and transition zone of 25 millimeters in size, with extension to extraprostatic, extracapsular extension in the periprostatic tissue, and there is signs of extension in the right seminal vesicle. And later it was done CT. I can show the metastasis in the tibia on CT. So there is a large focus in the tibia. So sclerotic, so it's very suspicious on CT. The signs of sclerotic bone focus is suspicious for prostate metastasis. Always. So, Barbara?
Yeah. So also would like to add that he does have some pain on the leg at this particular moment. So I would like to continue the discussion about the treatment, or maybe to start it.
For radiation for bone?
First of all, I have a couple of questions. Why after rib resection it was applied radiation therapy? It's actually, I'm not sure about that. But we don't have data about that. Yeah.
I cannot answer it.
And it was radiated prostate with lymph nodes, yes? It was definitive treatment, yeah?
Yeah. HDR with the external beam.
And so maybe question is for pathologist, is it necrosis? I don't follow. Is it necrosis or is an active prostate cancer cells was found after biopsy of tibia?
In fact, I would like to start from. One moment, please. I would like to start from biopsy because the biopsy still was done in the National Cancer Institute, and it was on all of 4 biopsies from right lobe was extensive tumor in all looks like in all biopsies it was identifiable tumor of Gleason 3+4 category with isolated glands and also with some fusion of glands, and extension of the tumor was up to 40 millimeters in higher dimension. It was the first biopsy when the findings from the coastal metastasis, not coastal, sorry, coastal, fifth coastal metastasis, and the tumor it is also the tumor of higher Gleason grade. Probably of Gleason 4+4, infiltrating nearly all the biopsy, and after that biopsy. Yeah, it was biopsy from 2018, and the last biopsy was taken in 2024, 1 month ago. And in this biopsy, we don't see any tumor, only blood and only some necrotic tissue.
We don't have any cancer cells.
Yeah, in the last biopsy, we don't have any viable or residual tumor. But of course, the biopsy couldn't not represent all the situation.
And maybe does patient has any symptoms, pain, for example, in this TBA?
Yeah, he did have some pain, even though his ECOG is at 0, but he did complain of pain.
Okay. So should we go for radiation therapy? I think we should wait for radiation therapy because at the moment we don't have any morphological verification. And this patient, as far as I understood, he has hormonal therapy, yeah?
Yes, main question is he hormone sensitive yet or hormone refractory?
Yeah, he was on long-term hormonal therapy. However, now the PSA level is increasing.
It's an unknown situation about at testosterone level castrate.
Yeah, cannot tell you this one.
Castrated.
Yes, and in this case, I think we need more data about what I said. Is the patient hormone sensitive or hormone resistant at this time? And also about distant metastasis. Is it metastasis in tibia? But it's not verified. Nobody knows. Nobody knows.
It was presumed. I think.
Yes, it's. We need clarification to make decision about treatment. I think about distant metastasis, maybe CT scan, body CT scan, chest, abdomen, pelvis. Not done.
So no, it was done. It was only the tibia was found with the pathology.
Tibia on scan, not on. Or
it was done as well. No, it was done. There was no distant metastasis found.
Only one suspicious
lesion in tibia. Yeah,
but did not proven morphologically. And what about PSMA scan? Maybe
not yet.
If we imagine that we had a testosterone castrate level, what about the PCW time of this patient? Do you have calculated?
No.
If we have hormone resistant case, I think ADT. We need to continue ADT plus novel anti-androgen therapy and clarify situation. To do testosterone, to do maybe PSMA scan, if it is possible.
I think that systemic treatment is needed in this case, and maybe radiation therapy for tibia can be considered later. Any symptoms
delay for
or
a while, yes. And to repeat this question again in future.
So PSMA.
Yes, some radiological examination.
Yeah.
Testosterone level.
Yeah.
Any systematic treatment, yes, Dr. Sadowski? Sorry. What systemic treatment will you offer?
No.
I will recommend clarification as we discuss now, are discussing now, and I think about ADT plus novel anti-androgens in this case for first line.
And maybe doctor,
if it is hormone resistant for first line, novel enzalutamide, abiraterone.
If you don't have metastasis. No metastasis.
If no metastasis.
Apalutamide.
We have discussed about apalutamide, maybe.
If you have hormone-resistant cancer.
And maybe Dr. Tiškevičius knows about bone scan for this patient. How you feel? Was it
Yes.
met in tibia?
Actually, I can't present the images because I'm isolated at home and don't have access to the PACS system. But I remember this patient, and there was only one suspicious lesion, large lesion in the proximal tibial metaphysis, and no other suspected lesions in other parts of the bones.
But it was no doubt that it can be metastasis, yeah? It was no doubts in tibia, or you had some thoughts about
Actually,
that?
it's a very interesting case, because it's very rare to see isolated metastasis in tibia in prostate cancer. We have patients with very high metastatic load to whole skeleton, but the tibia usually are free of metastasis. So it's a bit unusual case, but this lesion is very suspected for prostate cancer metastasis.
And I think that radiation therapy should be a little bit delayed. No hurry for radiation to tibia. And systemic treatment, of course. Yep.
Thank you very much.
Maybe colleagues have some suggestions more? Doctors, maybe you have some recommendations for these patients for examination or treatment?
Maybe in Santara Clinica, doctors from Santara's Clinica think otherwise. Have some thoughts, maybe Thomas or Arnas?
No, I agree. If we have a castration-resistant phase metastasis in the bones, so we should think about systemic treatment because the PSA is rising under the hormones.
Maybe.
No more comments, questions?
We should close our MDT. Thank you all participants for this for those nice cases. Thank you all of you. Thank you all experts. Thank you for all opinions.